Examine this person's legs, the sensory system, the sensory system, the sensory system, the sensory
I'd like to begin by testing pinprick first, because it's more spatially discriminating. Pinprick. You have two options of which spatial pattern to follow. A length-dependent approach, or following the dermatomes upwards. Which pattern you follow will depend upon the findings of the history and motor examination. For example, if a peripheral neuropathy is suspected, then a length-dependent approach, looking for a stocking distribution of sensory loss, would be most appropriate. This will be the approach that you use most often. Hold the neurotip between the finger and thumb. Close your eyes. Do you feel this nice and sharp? Is it as sharp here? Tell me if it gets sharper. Advance in small steps up the leg. If there appears to be a cut-off when the pin feels sharp again, check that this is likely to represent a length-dependent sensory loss by repeating the same up the back of the leg. However, if the findings so far have been suggestive of a spastic paraparesis, for example, then it might be more appropriate to start with a dermatomal approach. Start at S2, which forms a long line up the back of the leg, testing it above and below the knee. Then the sole of the foot, S1, the lateral aspect of the lower leg and over the big toe, L5, the medial aspect of the lower leg, L4, the medial aspect of the knee, L3, then L2 and L1 over the thigh. Then advance in small stages up the anterior aspect of the abdomen Repeat this for both sides up the whole of the torso. It may be necessary to continue your examination over the arms, testing the cervical dermatomes. If a pinprick sensory level is apparent, then confirm its anatomical plausibility by testing over the back. The level should be a little further up on the back compared to the front of the torso, since the thoracic dermatomes slope downwards as they wind around the trunk. Similarly, if you suspect compression of a particular spinal root on one side, for example L5 or S1, then a dermatomal approach will be more informative than a length-dependent strategy. Joint position sense. Start at the big toe. Hold the big toe with your fingers on either side to avoid giving pressure cues about the direction of movement. With the patient's eyes open, show them what constitutes up and down. That's up and that's down. Now close your eyes. Tell me if I've moved up or down. Young people should be able to detect even small movements. Make consecutive movements. Do not return to the baseline position between movements. This confuses the patient. How much credence you give to an occasional error will be a matter of your own judgment. If small movements of the big toe are not detected, then try full range big movements of the big toe before moving on up to the ankle. If the patient is accurate in detecting the big movements of the big toe, then joint position sense is graded as big movements at the big toes. Vibration sense. Do not strike the fork, which will create an audible tone, but set it vibrating with a flick between your fingers. Close your eyes. Do you feel that vibrating? Do you feel it down there? If they do not feel it at the big toe metatarsobapharangeal joint, then move up until they do in the following order: lateral malleolus, fibular head, greater trochanter, anterior superior iliac spine, costal margin. To complete my assessment of dorsal column function, I would also like to test light touch.